Thank you. Yes, I mean, retinal diagnostics are becoming increasingly important, but residents should be taught clinical skills first. If they are taught how to diagnose things, how to suspect things, then probably every case, what they suspect would not require retinal imaging. So retinal imaging with technology has become the fad in today's era. The clinical skills are taking a back foot because you are going in for everything like an MRI that yes, I will have a simplified printout of something and then I'll go retrospective in my diagnosis. But first and foremost are the clinical skills. These retinal imaging diagnostics are machine-based and are prone to errors and artifacts. And here comes the role of the clinical acumen. So for residents, I feel that they should have first learn how to examine a patient properly before going into the retinal diagnostics. Retinal diagnostics is expensive. These machines are not affordable to everybody, and so a tailored approach is what is needed. The interpretation of this complex imaging is still not standardized, and the algorithms require expertise. They differ from machine to machine. They have artifacts. So sometimes if you just try to rely on these machines, then things can go wrong in the treatment. It may bring out lesions which are benign, but that may put a psychological stress on the patient. So everything is not retinal diagnostics. You have like OCT, you have FFA, ERG. These cannot be relied upon alone as a tool for diagnosis. These may be misleading if a proper clinical exam is not done. So first and foremost, like if you have a disc, now whether that is glaucomatous or a neurological, should be the clinical acumen rather than sending the patient for getting an OCT done and then going back and seeing what it is. We have the adverse effects of ICG and FFA, which are well known. These are invasive tests. These cause hypersensitivity reactions. So patients, if you just order, if it's a resolving papilledema and you think of it's like an anterior ischemic optic neuropathy and order an FFA and the patient gets a reaction, probably those retinal diagnostics are not really required by the residents. It's more of clinical examination, evaluation, whether the patient has a field defect, is it altitudinal, how was the vision loss, and all these stuff. So these can prove fatal in those with renal disorders or liver problem if ignorant about the patient history. So the resident should see the patient as a whole and not just be looking at the eye if you're going in for the retinal diagnostics. So there is a difference between the results of different machines which measure the same parameter, and this could lead to confusion and interpretation because these machines are still not standardized to give a progression as they just give out a simple anatomical printout of what is going on. There has started a race for machines rather than skills with this advancing technology, which I feel the resident should not be a part of. However, even though legal battles force one to over-investigate, retinal diagnostics should not overpower our clinical thinking. Thank you.